That's our treatment for overdose. Okay? We're going to talk about some specifics, but in general, we just want them to not die. Okay, so let's talk about how we prevent that and what that looks like and when we need to be concerned that they might die. All right, so we have abuse versus addiction, and this is just a 114 review. All right, abuse is habitual use that falls outside of medical necessity. Use falls outside social acceptance. Use is for single purpose of altering mood, emotion, or consciousness. This is not you taking your prescribed Percocet after surgery. All right, this is you taking your friend's prescribed Percocet and you're taking way more than you're supposed to be because it makes you feel good. All right. Addiction is chronic relapsing brain disease. There's a compulsive drug seeking motivated by cravings. The compulsion occurs despite harmful consequences. You're never going to be able to out-consequence a drug addict. Right? This is a brain disorder. And it results in long-lasting brain changes. Right? Commonly abused substances. I like this graphic here because it tells you the average age of substance abuse by the gender. So you have alcohol, tobacco, marijuana, prescription drugs, cocaine, heroin, methamphetamine, ecstasy I haven't seen in a while, hallucinogens, and inhalants. All right, what do you notice about these ages? They're young, all right? Most of them are teens. So your teens are using drugs a lot. Why? Risky behaviors, right? Goes back to Erickson. They think that they are not vulnerable, right? That nothing bad will ever happen to them. They engage in risky behavior, and my friend did it, and he felt really good, so I think this is a good idea. Okay? How do different substances act differently in the brain? There's a little explanation that I'm not going to read, but we know that different things are going to do different things in the brain. Do note when you're looking at a UDS and your patient pops positive for methamphetamine, what else will show a positive methamphetamine screening? Adderall, right? Your stimulants will. So don't assume that your 8-year-old is on methamphetamine or is taking meth. Make sure we know that they don't have a prescription for methylphenidate. All right, assessment findings. If you look in that book that is linked, there are detailed assessment findings about what a patient would look like if they are intoxicated with a substance versus if they have taken an overdose of a substance. It's much more detailed information than you need, but it is good information. So I do recommend at least glancing through that. I don't recommend memorizing the chapters though. All right, so if we're looking at CNS depressants, obviously depression are going to cause drowsiness, hypotension, slurred speech, impotence, impaired memory and judgment, and unsteady gait. What CNS depressant can you think of that you've seen cause these symptoms? Alcohol, yes. What'd you say?
Morphine.
Yeah, morphine also, right? We can also see it with benzodiazepines. All right, opioids. We have an opioid epidemic, so you are probably going to see lots of questions on opioids because it is what is out there that we need to make sure we are treating. You can see constricted pupils, drowsiness, euphoria, hypotension, slurred speech, and bradypnea. What's bradypnea?
Slowed breathing.
Right, slowed breathing. Stimulants, we have dilated pupils, hypertension, nausea, vomiting, impaired judgment, paranoia, tachycardia. They may become violent. Okay. What stimulants do we often see patients come in on?
Cocaine and methamphetamine.
Cocaine and methamphetamine, yes. Hallucinogens. We see agitation. We don't see as many hallucinogens, but I've had a couple of patients in the past 6 months or so that have been positive for hallucinogens. Agitation, dilated pupils, hypertension, diaphoresis. They have bizarre behavior, muscle rigidity. They can have seizures, tachycardia, and tremors. And then inhalants. Who do we typically see using inhalants? Teenagers, yeah, they do the huffing. Euphoria, enhancement of sexual pleasure, and excitation. All right, so what are we going to do about it? Pharmacological treatment of overdose is going to depend on what the substance is. If we're not sure what the substance is, what's the first thing we're going to try to use? Narcan, because we're in an opioid epidemic, right? So we have naloxone, which is our antidote for opioids. What would count as an opioid? Morphine. Fentanyl, well, yeah. Oxycodone, yeah, all those things. All right, flumazenil is my antidote for benzodiazepine. What's an example of a benzodiazepine?
Lorazepam.
Lorazepam, yes. Diazepam. All the PAMs. All right, I can also use lorazepam for treatment of agitation from stimulant overdose and hallucinations. What else can I use lorazepam for? Seizure prevention, specifically in what?
DTs.
Yeah, DTs, alcohol withdrawal. All right, I can also use phenobarbital to treat seizures related to stimulant overdose. And I may need to use phenobarbital in my alcohol withdrawal as well if lorazepam isn't cutting it. All right, signs of an opioid overdose. Main thing that we're gonna see is slowed respirations. It's gonna concern us for opioid overdose. All right, they're also gonna be unresponsive. They may be choking, may have cold or clammy skin, may be dizzy. Pupils extremely small, I would know that one, constricted pupils. And then discoloration of lips and nails, what's that? Cyanosis. All right, if we are treating for an opioid overdose and we are using naloxone, we're gonna use it until we get response. So we'll give it, and then in about 2 minutes, if we haven't got a response, we're gonna give another dose of naloxone. Huh? They are, yeah. They're not gonna wake up happy, but they're gonna wake up. So that's good. If we are having to treat flumazenil, we're trying to treat an overdose of benzodiazepines, we have to be really careful with that one because we can actually induce seizures by reversing that benzodiazepine. So we use it if we absolutely need to, but we need to make sure that we're being very careful, especially if this patient is a benzo user habitually, because we may cause some seizures. All right, a review of 114 stuff for drug addiction. How do we treat it? Therapy is our #1 way. We do have some medications that we can use. These are going to ease withdrawal symptoms, all right? So things like Suboxone, or if we have alcohol that we're trying to treat, we may use disulfiram. What's disulfiram or Antabuse is the name brand?
Makes them really sick if they drink.
It does, it makes them really sick if they drink, okay? So that is when we're using for addiction treatment, not during withdrawal, because your patient has to be competent in order to be able to answer, does he want to agree to take that treatment or not? All right, and if that patient doesn't want to, then we really messed them up. All right, behavior therapy, hospitalization to detox before beginning long-term treatment. And what are we doing during detox?
Slowly.
Easing them off, right? So we may use like benzodiazepines to ease those symptoms of alcohol withdrawal. We want to make sure that they're coming off of the drug safely, that they're not just stopping abruptly, because that can cause some serious problems. And then we want support groups. So things like AA, NA, those work really well for addiction. Questions about that? That's all 114 review. All right, pharmacological treatment for opioid withdrawal. So if we have a patient on opioids who is withdrawing, then we can use methadone. This is the most effective against heroin. It's gonna block the craving. We have buprenorphine or Suboxone. This blocks the signs and symptoms of opioid withdrawal. Again, we're decreasing those cravings. Now, Naltrexone is an interesting one. It's an antagonist that blocks euphoric effects of opioids, decreases alcohol cravings. We can also use it in opioid cravings. We also use naltrexone in self-injurious behavior. So we've had some patients who are habitual cutters, and they cut because the release it gives them. It releases that anxiety, increases the dopamine in the brain, makes them feel good. So naltrexone blocks that response, and we've seen positive responses from people taking that for cutting. And then clonidine. What is clonidine? It's a blood pressure medicine that does all kind of stuff for our mental health patients. All right, so if you have an 8-year-old on clonidine, why are they taking clonidine? Not for blood pressure. It's for ADHD, yeah. So my 3 main symptoms of ADHD are impulsivity, hyperactivity, and inattention. What do you think clonidine is targeting? Hyperactivity, and ideally the impulsivity as well. Yeah, so clonidine can be used for ADHD. It's not going to do a thing for that inattention, but hopefully will help calm them down. It can also be used with naltrexone to suppress opioid withdrawal symptoms. So it's an interesting little drug. What do we have to check for with clonidine? Blood pressure, right? Because my body doesn't know that I'm giving it for withdrawal symptoms. It just knows it's a blood pressure medicine. Same thing with ADHD. Doesn't know that we're giving it to the kid for ADHD and not blood pressure, so it'll still drop the blood pressure. It's also an interesting one that if it builds up in the patient's system, like if they take this every day and they stop clonidine abruptly, it can cause a rebound hypertension. So if they are taking it for blood pressure, we want to make sure they don't stop it abruptly. It can cause some really dangerous hypertension. Questions about clonidine or any of these? All right, nursing interventions for withdrawal or overdose. Again, ABCs are going to be our priority. We're trying to prevent death. So if they can't protect their airway, that's my priority, right? We need to know the type and amount of drug that is consumed, and that gets really important when we're thinking about withdrawal, because what has to happen before the patient withdraws? I have to stop it, right? So I need to know how long have they been off of that before I know if they're at risk for withdrawal. So especially when we're looking at alcohol and the possibility of DTs, one of those most important questions, and hey, how much do you drink? What do you drink? And when was the last time you had a drink? So I know when we are in the window risk for withdrawal. Okay, they need one-on-one supervision if they have overdosed. They need to be in a calm, quiet environment. Again, if we're thinking about a withdrawal with alcohol or opioids or benzos, then that withdrawal can cause some anxiety, some agitation, some restlessness. So we want to make sure we are keeping a calm environment. Reorienting the patient if it's needed. Make sure we're providing for safety, seizure precautions for my alcohol withdrawal patients, also for my benzo patients, especially if I've had to give flumazenil and this is someone who takes benzos habitually. We need to make sure we use security devices to prevent from further harm. These patients may meet criteria for restraints. We're going to give fluids. Who's going to be in the most need of fluids if I'm thinking about overdose? Your alcohol patients, yep. And not only do they need fluids, what else do they need?
Electrolytes.
They need electrolytes. Specifically, what one are we concerned about?
Magnesium.
Magnesium, because if my mag is low, what can happen?
Your cardiac.
What about cardiac?
It's a straight line.
Torsades, yes, torsades, 2 points. Okay, what else do they need besides electrolytes? They need a couple of things. Folic acid, okay. Yeah, so what makes it yellow?
The B12 or the thiamine.
The thiamine, yes, they need thiamine. And they also need, with that thiamine, what kind of fluid does that need to be in? Dextrose, they need some dextrose. They need glucose support. Alcohol can drop your glucose, but also what we're trying to do is give the brain glucose to prevent something called Wernicke's encephalopathy. Did y'all hear about that last semester? Okay. All right, and then we're gonna collect labs for drug screening. How do we drug screen?
Usually urine test.
Usually a urine. There's some things we can test for with blood though. All right, let's do some practice questions. All right, while I'm I'm pulling up practice questions. What's my priority with overdose?
Keep them from dying.
Keep them from dying, yes. Outside of keeping them from dying, important assessments are gonna be things like,
Respiratory.
what do you take? How often do you use it? And when's the last time you used it? All right. The nurse in the hospital emergency department is caring for a client with suspected opioid overdose and is preparing to administer the reversal agent via the IV route. Which statement is correct about the administration of this medication? What is the medication that we would use?
Naloxone.
Naloxone, yes. Okay, so what are we gonna do?
4.
Okay, 4. Anyone actually have any idea how we give that medication?
I've only ever given it nasally.
Yeah, you can give it nasally.
I've never seen it done IV.
You can also give it IV. I have no idea how we would give it IV, but I can still answer this question.
Surely it's just a push, right? I don't think, it wouldn't be a drip. That doesn't make any sense.
It doesn't make any sense. No, it should be a push. So prepare only 1 dose of the reversal agent. Why is that not correct?
Because of likelihood that
Might need more, yeah. So again, even if we don't know how to give this IV, we can get to the right answer. Administer the entire dose by slow IV push or administer the medication by rapid IV push. Why do we mark those out?
It can be right both.
Right, they're opposites of each other, so generally, that's not gonna be the option. All right, after the initial dose, prepare to administer additional IV doses if needed. This is just a good, all-around, encompassing, safe answer. So, this is my best answer. All right, any questions about that one? I specifically pulled that one to kind of talk about how we can get to the right answer, even if we don't know the information. The home health nurse visits the client at home and determines that the client is dependent on drugs. During the assessment, which action would the nurse take to plan appropriate nursing care? Two, yeah. Why is it not 1?
doesn't matter on.
That's not the priority, right? And it also sounds real judgy. What about 3? Why is that not the answer?
That's definitely also.
Definitely judgy, yeah. And why not 4? Right, we're not just gonna ignore it. Okay, so 2 is the best answer. Ask the client about the amount of drugs used and its effect. That's gonna tell us what she's using. It'd also be a really good option to say, hey, when was the last time you used? And then we need to do some assessments. Which interventions are the most appropriate for caring for a client in alcohol withdrawal? We like 1,
2.
we like 2,
3.
we like 3. What kind of hallucinations do we commonly see in alcohol withdrawal? Visual and tactile. Bugs are crawling on my skin. They're everywhere, right? Or I see the bugs crawling on the ceiling. Okay, what about 4?
No.
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 What about 5?
Yes.
Yes.
Yes. And what about 6?
No.
No, we don't need them to be NPO unless they can't protect their airway. Before giving the client an initial dose of disulfiram, what would the psychiatric home health nurse determine?
4.
Yeah, why?
Because it's a drug for delirium, like the stuff that happens with alcohol.
Causes that significant, intense reaction, right? Severe nausea and vomiting if they take disulfiram with any alcohol. I like to test on disulfiram. Standardized tests like to test on disulfiram because of that reaction, and education is so important. That's when I would make sure I look at. A client who is overdosed on benzos is drowsy but arousable. The nurse should anticipate which medication order. B, right? That's my antidote for benzos. But I would use it with care. Why?
Because it could send you to the seizure.
Could induce seizures, correct. Client is admitted after an acetaminophen overdose. Which lab value is the most important to monitor?
A.
It's a liver thing, yeah, so which one's my liver test? B, yeah, we have to measure liver enzymes. A nurse is caring for a client with an unknown overdose who is unconscious. What is the nurse's priority action? B, yeah, ABCs, right? Let's make sure that they can protect their airway, that their blood pressure is okay, that we don't need to support them any other way. We wouldn't give activated charcoal without knowing what the substance was. There are some things we use activated charcoal for, but we're not just gonna give it because, right? Insert a Foley catheter is not the priority, and obtaining a urine drug screen is appropriate, but not the priority. I need to make sure they're breathing first. Client presents after an overdose of a TCA. The nurse should monitor closely for which complication? What kind of medications are TCAs? These are antidepressants, so doxepin is an example of a TCA. B is correct. These are known for cardiac arrhythmias, and they can cause seizures and overdose, and they are lethal in overdose, and they are ones that we would use the activated charcoal for if they overdosed on them. They're not medications we would give to someone who would potentially be a suicide risk because they could take their bottle and kill themselves. Are you gonna take a bottle of an SSRI and kill yourself? Probably not. You're not gonna feel real good, but it's probably not gonna be lethal. This would be lethal. A client who overdosed on heroin is now awake but agitated and vomiting after naloxone administration. What is the best nursing action?
B.
B. We're not gonna give a second dose of naloxone. Why? We've seen a response for our medication. We don't need to give more. Why are we not gonna restrain?
You're not hurting anyone.
There's nothing in this question that tells me that they meet criteria for restraints, right? Why are we not gonna administer activated charcoal?
There's heroin.
Right, and they're responding, so they don't need anything else. The nurse is caring for a client admitted for intentional overdose, which nursing diagnosis takes priority once the client is medically stable.
D.
D, why not C?
Cause it's suicide.
Right, because it's saying that it is an intentional overdose. Okay, so D is the most appropriate answer. Why is it not B, ineffective coping? Because we're looking at Maslow, right? So Maslow tells me that once the bottom is met, which it tells me that the client is medically stable, I move on to safety. So I've got two things up there that address safety, C and D is the one who addresses what is actually going on with my patient. Which statement by the nurse demonstrates appropriate therapeutic communication with the client recovering from an overdose? You know it's not A.
B.
Okay? Anyone like anything else? No, I like B too. Why not C?
It's
Jim.
It's judgy, yeah. It's also telling them, hey, you gotta do this. Right? We don't do that to patients. Why not D?
Blame.
It's blaming, yeah. The nurse would monitor a client with a history of opioid abuse for which signs and symptoms associated with opioid withdrawal?
Two.
It's not 2. 2 sounds like something else though. What's it sound like?
Alcohol.
Yeah, alcohol withdrawal. It's not 3, it's 4. And the big thing is, yawning is a weird symptom that is associated with opioid withdrawal that I always. Questions about that? Okay, let's talk about suicide. Y'all need a break or y'all good? All right, so, suicide. And here we're talking about suicide prevention, because if a patient has committed suicide, then what has happened?
They're no longer.
They are no longer with us, right? So if it's a successful suicide attempt, then they have killed themselves. So we want to prevent that, obviously. And Joy Commission has identified this as one of their patient safety goals for about the last 10 years. They want nurses or hospitals in general to identify patients that might be at risk for suicide and make sure that they have access to resources. So some resources are listed up here. There is the National Suicide Prevention Lifeline. There's a phone number, but you can also just call 988. And I believe you can text that number as well. And then there's some statistics. Nearly 46,000 people died by suicide in 2020. All right, there's one death every 11 minutes. Many adults think about suicide or attempt suicide. 12.2 million seriously thought about suicide, 3.2 million made a plan, and 1.2 attempted. All right, suicide risk factors include a previous suicide attempt, history of depression or other mental illness increases your risk, serious illness or chronic pain, especially if that serious illness is a terminal illness, that increases your risk. If someone has criminal or legal problems, especially if they're feeling trapped by those criminal or legal problems. If we have job or financial problems or loss. If the patient is impulsive or has aggressive tendencies, and anytime we see the word impulsive and we're thinking about mental health, that should tell you that there is a risk of harm. It's either gonna be to themselves or others because they may not think through that decision. Substance use increases your risk, and if you have a dual diagnosis, that's gonna increase it even more, meaning you have a diagnosis of a mental health illness and substance use. Current or prior history of adverse childhood experiences, what are those?
Abuse,
Mm-hmm.
neglect, anything like that?
Right, so those are negative things that happen in your childhood that can impact you into adulthood. So that might be things like divorce, one of your parents going to jail. It can be abuse in the home or abuse to you. So there can also be community adverse childhood events. So witnessing a traumatic event in the community. So all these things can increase your risk for mental illness, your risk for suicide, and it also increases your risk for physical illnesses as you get older. A sense of hopelessness, of no control, and then violence, victimization, or perpetration. So either being the victim or the perpetrator of violence. All right, here's some warning signs of suicide listed over here. People who are talking about wanting to die, they have a lot of guilt or shame, feel like they're a burden to others. Those are warning signs. If there's hopelessness, they feel trapped. They're extremely sad or more anxious, or they're very angry, so extreme feelings. Unbearable emotional or physical pain. If we have changing behaviors like making a plan or researching ways to die. They're withdrawing from their friends, saying goodbye, giving away important items is a big one. Making a will. They're taking dangerous risks, like driving too fast. We had a patient recently who walked to a bridge 12 times, didn't jump, but was walking to the bridge. We have extreme mood swings. They're eating or sleeping more or less. And drugs and alcohol is going to increase the risk. All right, suicide assessment tools. Do you guys go back to Psych? Are you all done with your Psych clinicals? Okay, if you go back and you get in the chart, they do suicide assessment on every patient every 12 hours. Get in your chart and look at your suicide assessment. They do the Columbia Suicide Scale, so this one over here. You could see either of these on standardized test. I just care that you can look at it and kind of know how to do it. I don't want you to memorize these. You never need to memorize a scale, but do kind of know what they're asking about and what it means with what your patient gets, okay? So this suicide screener, it tells you, hey, you want to ask these questions just like they are on the card. Okay, so this one says, over the past 2 weeks, have you felt down, depressed, or hopeless? And And you're gonna say yes or no. And it tells you if they say yes to item 1, then it's a positive screen for depression. All right? For number 2, over the past 2 weeks, have you had thoughts of killing yourself? You're gonna ask it just like that. Okay, so yes or no, and it tells you right here if you have yes to item 2 or last 6 months to item 3, it's a positive screen for a suicide risk. So number 3 says, have you ever attempted to kill yourself? And you say yes or no. And that's gonna ask you, have you done it within the past 24 hours? Have you done it within the last month? Have you done it between 1 and 6 months ago? All right, so this is looking at your patients and are they a suicide risk? Over here is gonna kind of talk to you about the severity of it. So have you wished you were dead or wished you could go to sleep and not wake up? That's gonna be a yes or no. Have you actually had any thoughts about killing yourself? And it's telling you that you're asking them about this in the past month. On the unit, they're asking in the past 12 hours because they got assessed 12 hours ago. They're doing it every shift. Great. Have you been thinking about how you might do so? And this is if they answer yes to 2, then you ask these questions. If they answer no, then you go down to 6. All right, but if they have been thinking about killing themselves, then we're gonna ask these questions. Have you ever had these thoughts and had some intention of acting on them? If they answer yes, then they are a high suicide risk. So that's what this means over here. All right, have you started to work out or worked out the details of how you would kill yourself? And did you intend to carry out this plan? And if they answer yes, they're a high risk. And then actually question 6 is, have you ever done anything, started to do anything, or prepared to do anything to end your life? And it's asking about lifetime. If it's lifetime, then it's a yellow, which is gonna be a moderate risk. This is a no risk. And if it's in the past 3 months, then they're a high risk. Okay, so looking at possible suicide risks. What clinical decisions might we make if someone is a high risk of suicide?
Remove any ability to do.
Yeah, how would we do that?
Sanitize the room, clean it with like no sheets or anything they can hang themselves with.
Okay,
Maybe monitor them.
I like monitoring. 101, yeah, so they're gonna be line of sight or 101, meaning that that patient doesn't go anywhere without eyes being laid on them. They go to the bathroom, someone watches them. They take a shower, someone watches them. They're probably gonna sleep in the hall at East Alabama, but that's a facility thing. That might not be true no matter where you are. And that's just for easier monitoring so we can see where they are. They're not gonna be able to go in their room because they don't have a staff member that can sit in the door and watch them in their room. So they are watched very closely, 101, so that there is no possibility of them harming themselves. All right, nursing interventions for your suicidal patient. Initiate suicide precautions. That's going to be the 101 supervision, making sure that if you aren't already in a room that is safe, like on the psych unit, if you're on a med-surg unit, that you clear that room. And those of you going back to the unit, if you'll look on that screening, it tells you that if they're a moderate or high suicide risk, you need to look at these things specifically in the room and get rid of them. So it talks about hand sanitizer, sharps containers, anything that's movable that they could hurt themselves or someone else with, their personal belongings, belts and cords, all of that stuff. Make sure we're maintaining safety. Now again, that's gonna look like not giving my patient access to things that are gonna hurt, that they can hurt themselves with. Listen and acknowledge feelings. Don't ignore the passive signs. So someone who's just like, oh yeah, maybe I'm thinking about killing myself. Or some patients have just passive suicidal ideations. We don't want to ignore those. Passive suicidal ideations meaning they think about dying, but they don't have a plan. Okay, we don't want to ignore that. Identify if a plan has been made. And if they do have a plan, we also want to acknowledge, is it a plan that they could carry out now? Okay. A plan is a plan, and it is an increased risk of suicide. But if we have a patient whose plan is to specifically drive across the country to the San Francisco Bridge and jump off of it, well, that's not something that they can do on our unit. Still gonna watch them for it, but that's much different than I'm gonna take my sheet tied around my throat and kill myself.
on a psych unit, but it was a regular hospital bed. And she wasn't a one-on-one, but she came in for suicide, and she was brand new. And I think I went to lunch, no, I know I went to lunch, and I came back, and I heard somebody coughing, and I'm like, coughing for her. So I walked in her room, she had raised her bed up to the highest it would go, wrapped the sheet around it, and it slid down.
Oh,
So,
was she okay?
yeah, she lived, she was very upset.
So we're gonna administer medications as prescribed. What kind of medicines can we give? Antidepressant. How long does it take to work?
30 days.
Couple weeks at least. And then there's that scary period for a couple of months where the medicine has started to kick in, but their depression hasn't lifted. Now they have energy though. So it's an increased risk of suicide period because they have energy to act out their plan. But yes, antidepressants would be good if depression is there. Patients don't always attempt suicide secondary to depression though. Sometimes it's a borderline patient. And what do we know about borderline patients? What is borderline personality disorder? Y'all have the same look on your face. So some of the characteristics of borderline personality disorder are very intense relationships that are not stable. They tend to see people as either all black or all white. This is called splitting. All right, and because of that, they tend to have overreactions when they are rejected. So if someone says that they are going to break up with them or they are going to leave them, then you may have a patient who attempts to kill themselves in response to that. And oftentimes those attempts aren't as severe, but one of our psychiatrists had a very good point, and she said, you know, my borderline patients are my scariest patients to attempt suicide. Not because the attempts are severe, but because they will try again and again and again. So we have to be very aware of those things. What medication can I use to treat borderline personality disorder?
A mood stabilizer.
There's not one.
Um,
So
also,
I
don't
can
know.
give some medications for depression, and if I have mood instability that is pretty significant, then I can use a mood stabilizer. It's not gonna treat the personality disorder though. That's only gonna get better with therapy. All right, and then I may need to restrain my patient as prescribed. So we have a patient who comes to the unit fairly often who is severely schizophrenic, has hallucinations that tell her to harm herself, and she is always one-on-one, at least when she is first admitted, because she will do things like climb up on her sink and throw herself in the floor because the hallucinations are telling her to do so. So sometimes she has to go in restraints to keep her safe from herself. All right, questions about any of that? Okay, let's talk about securing the room. We want to make sure the windows are locked. Again, if you're on the psych unit, this has already been done for you, which is nice. But remember, your mental health patients and your suicidal patients don't just hang out on the psych unit. They can be on any floor. So you want to make sure that you know how you're going to handle this if it's your patient on a medical floor. Break-proof glass and mirrors. You've got glass in the medical floors, so you don't have that on the psych floor. So how are you going to handle that? They need plastic flatware, and sometimes we won't even give them flatware. They have to use, we'll use a styrofoam cup to cut out a spoon so that they can use that because they can't hurt themselves with that. Make sure you secure any cords, and that's going to be really difficult in a medical floor, which is why they really need to get to a different floor as soon as possible. They're going to have to be one-on-one while they're on the medical unit. They don't need any belts, no matches or cigarettes, no sharps or razors. Think about your sharps containers that they can get in. Okay, and patient care we kind of already talked about. Except for that written behavior contract. So what is that? What's a behavior contract?
A contract with you and your patient that says if you do this, you know, pretty much they agree with you not to do
Right.
this.
Right, so it's your patient agreeing not to harm themselves. And so you might say, well, they're just gonna say that, and then they're gonna do whatever they want, and they might, but that still might be improvement, especially if they came in adamantly refusing to agree to safety. So it still could be improvement. Now, we might not trust it, we might leave them on line of sight for a little bit and make sure they're gonna uphold their end of that agreement. But it's a step in the right direction. Okay, questions? Why would we wanna monitor and restrict visitors on a med-surg floor? We know we do that on the psych floor.
Oh,
Agitation.
not good visitors,
Agitation, what else could they do?
Triggering.
raining stuff.
Exactly. Hey, can you bring me a sweatshirt? And that visitor has no clue why they don't need a sweatshirt that has strings, right? Hey, they took my belt and I really need one. Can you bring me a belt? And they're just trying to be helpful. All right, suicide prevention, identifying those at risk by using screening tools. Supportive care, meaning we're with our patients, we're therapeutically communicating. Acknowledge their feelings, we're not gonna dismiss it, we're never gonna say, you've got so much to live for, everything is gonna be just fine. You don't know what they have to live for, and you don't know that everything's gonna be just fine. They may be in a situation where things are not gonna be okay, okay? So we're never gonna give false hope. We do want to encourage them to point out positive things, so help them identify their protective factors. What are protective factors?
Things that they feel, that make them feel safe.
Right, so these are things that are going to help protect them from suicide, basically. So that would be things like a good support system or goals. So when we look at adolescents who come in with suicidal ideations, psychiatrist is always gonna ask them, how are you doing in school? How do you like school? Do you have any friends? Because if they're interested in school and they have goals and they have at least one or two friends, they can identify these are protective factors. So those things that are gonna work in their favor. Decrease access to lethal weapons, medications, and objects. How do we do that? Take them away on the unit. How do we do it when they get home?
Safety contract.
Yep, safety contract, and we need to communicate with family. So we need to make sure that they know, hey, if you have any guns, they need to be locked up so patient can't get to them. We need to lock up all medications. We need to lock up any weapons that are there. We need to make sure this patient isn't left alone by themselves for extended periods of time, at least for a little while. Okay, so we need to contact family and communicate with them. Now, if it's an adult, we have to have permission to do that, yes. Was that your question? Yes. But that also is a lot of times part of our discharge planning. Hey, if you're an immediate risk to yourself or others, even if you don't wanna have treatment, you're gonna get treatment. We're gonna court order you. And in order to drop that court order or dismiss you, I need to be able to talk to your family to ensure safety when you leave. So, frequent follow-ups. And then there is the CDC website there. All right, any questions? The main thing with suicide is keeping them safe. Making sure the environment is safe, making sure we communicate to keep them safe at home. We'll also want them to create a safety plan before they go home. And just like we have a safety plan for those patients that were victims of violence, we want it to include very specific things. So it's gonna include things like, hey, what are your triggers? And when those triggers happen, what are your coping skills that you can use? If those coping skills don't work, who are the safe people you can call and where is the safe place you can go? And then what are your emergency phone numbers? So just like we don't think of where is the safe place in our house when the tornado is over our house, we don't wanna be figuring out how we're gonna deal with a mental health crisis in the middle of a mental health crisis. We wanna already have a plan in place. Questions? All right, I've got some for you. A homebound client confidentially discusses suicide plans with the visiting nurse. Based on professional duty to observe confidentiality, which statement describes the nurse's obligation to the client? It's 4, yep. Remember, that's why we never say whatever you say is gonna stay between me and you. Because if there's a risk, we have to communicate that with the care team. Any questions about that one? Okay. The nurse determines that which client is at highest risk for suicide. Okay, why 4?
Hopeless.
She uses drugs and alcohol, and then she's not gonna graduate, so.
Right, so there's a lot of
Multiple
stressors going
factors.
on. There's also drug use involved and age, teenagers. They're impulsive. We have a high risk of suicide in teenage years. What is the appropriate nursing intervention in dealing with a suicidal client? This is really just any client.
It's not 4.
It's not 4,
3.
okay? Anyone like anything else?
I also like 1, so I'm kind of.
Yeah, so it's definitely between 3 and 1. So let's talk about it. 1 overall, is there anything negative about 1? Do we want to provide authority for our patients who are in crisis?
Yes.
Yes, we do. All right, do we want to provide action for our patient? Yeah. And what about participation?
Mhm.
Yeah, we want to be a part of that care. All right, let's talk through 3. Demonstrate confidence in the client's ability to deal with stressors. Do we want to do that?
We don't want to
I
give
mean,
them false
you wanna be
hope.
confident, but you don't know.
Not participating in that.
Correct. So neither are bad answers, one is a better answer. The spouse of a client prescribed an antidepressant tells the home health nurse, now that the antidepressant is working, the suicidal risk is over and you can stop making these home visits. How does the nurse appropriately respond?
I wanna say 4.
4, that's what we were talking about earlier with the antidepressants, right? There's that scary period and it can last for up to like 3 months where the medicine has started to kick in, but we don't see full effect. And so they now have energy to act out on that suicidal plan. Which behavior observed by the nurse indicates a suspicion that a depressed adolescent client may be suicidal?
1.
1, yeah. Giving away the prized possessions, right? Adolescent runs out of the therapy group, swearing at the group leader to his own room. Is that indicative of suicidal behavior? No, that's aggressive behavior. Adolescent becomes angry while speaking on the telephone and slams down the receiver.
Aggressive.
That's aggression. Adolescent gets angry with the roommate when the roommate borrows the client's clothes without asking. It's just anger, so. 1 is correct. Which statement made by the assistant personnel indicates to the registered nurse that the assistant personnel understands the concepts related to suicide?
One.
Anyone agree with anything besides 1? One is correct. Okay,
All the other ones are false.
huh?
All they are false.
All the other ones are false. And asking a client about suicide or talking to them about suicide is not going to make them suicidal. Alright, so don't fear that. We want to be very blunt with our questions about suicide, very direct. We want them to know that's what we're asking about, but asking a question is not going to make someone suicidal. Which client is at greatest risk for committing suicide?
1.
Why 1?
It says terminal.
The terminal illness, yes.
Or like,
Everyone has a stressor, which is going to increase the risk, but there's nothing else in here that's as big of a stressor as terminal cancer. The nurse is performing an admission assessment on a client at high risk for suicide. Which assessment question will best elicit data related to this risk?
Do you have a plan?
Do you have a plan? Yes, so we should assess everyone for suicidal ideations, and if the answer is yes, do you have a plan? How is definitely spelled wrong there, how.
Our pans, you know? Do you have a
Oh, yeah. I'll fix that before I put it out. Do y'all have any questions about that? Client is admitted to the mental health unit after an attempted suicide by hanging. The nurse can best ensure client safety by which action?
3.
I like 3. Do y'all like anything else? Why not 1?
It's
You
not.
already got in the hospital.
Yeah. Peer cannot monitor your patient. Removing the client's clothing, why don't we wanna do that?
I mean, you do wanna put them in picture scrubs, but a hospital gown have a little.
I put down that string.
Yes, it does. So, and is there anything in there that tells me we need to take their clothes off?
No.
No. So why do we take someone's clothes off?
Their clothing and
Emergency.
Yeah, if it's at risk and we wanna search it. So usually we have them change into paper scrubs, search their clothes to make sure they're appropriate, and then give them back. There's nothing in here that tells me they just arrived. I don't need to take their clothes away. Right, admitted the client to a seclusion room where all potentially dangerous articles are removed. Why don't we wanna do that one?
They don't need to be by themselves.
They don't need to be by themselves. A client who attempted suicide by hanging is brought to the emergency department by emergency medical services. What is the immediate nursing action? Okay, I hear 2. Anyone like anything besides 2? Why is it 2 and not 1? Airway first, that's exactly right. That's it. What questions do y'all have? If y'all have any questions, let me know. This content is pretty streamlined. It's all about therapeutic communication. If your patient's at risk for dying, let's not let them die, and let's keep everyone